Maternal healthcare is both a global and historical issue. If we consider how the Western world received maternity care in the early 20th century, we notice that it revolved around home delivery with frequent visits by an obstetric specialist or midwife. The 1930s saw a shift in this process to institutionalized settings with a greater emphasis on postpartum follow-up, but still lacking adequate antepartum care. And if we look at Australian maternity care today, we see expectant mothers and their families being presented with multiple options for integrated antenatal, labour and postpartum care with input from multidisciplinary teams. Now we shift our attention to the developing world, where historically there has been a hesitancy to differentiate between maternal and child health problems due to a myriad of cultural and political factors. This issue was highlighted in 1985 by an influential Lancet article titled Maternal Mortality, a Neglected Tragedy. It questioned the assumption that the majority of maternal and child-associated mortality and morbidity could be addressed through improving antenatal and pediatric services, and why much of the international aid for providing maternal health only focused on family planning, during a time when professional postpartum care and emergency obstetric newborn care services were severely lacking. Following the release of that article, a newfound drive to improve global maternal health outcomes independently of child health outcomes was officially addressed during the first Safe Motherhood Conference in 1987 Nairobi. The Safe Motherhood Initiative, or SMI, is a policy that resulted. SMI was detailed and organised by the Safe Motherhood Interagency Group, IAG, who have worked together since 1987 to realise the goals of the SMI. The original goal in 1987 was to reduce maternal mortality by half by the year 2000, but this was not achieved, so the revised goals were then based on 3 of the new Millennium Development Goals. Briefly, these goals are: Goal 5, by 2015 to reduce maternal mortality by 3/4 and to improve universal access to reproductive health. Goal 3, to promote gender equality, and Goal 4, to reduce child mortality. The 4 pillars of the SMI that form the basis of the policies and programs integrated worldwide include family planning, antenatal care, clean, safe delivery, and essential obstetric care.
In terms of the progress of the Safe Motherhood Initiative, the maternal health field has made some substantial progress over the past 30 years. For an example, the global maternal mortality ratio has decreased by around 44%. Also, the use of magnesium sulfate in treating eclampsia and preeclampsia has shown drastic increase in the past 30 years. Given that uterine atony is the most common cause of postpartum hemorrhage or PPH, controlling PPH through active management of the 3rd stage of labor has been another critical aspect of this project. In this aspect, the most commonly used drug is syntocinon or oxytocin. Furthermore, screening for sexually transmitted infections or STIs such as HIV, hepatitis B and hepatitis C has now become routine during pregnancy to prevent or to avoid vertical transmission to the baby. Also, abortions are now done much more safely with the use of vacuum suction and other medical methods. Finally, the use of biometry and biophysical profiles around the world to measure the progress of the fetus is another achievement of the Safe Motherhood Initiative.
As mentioned, the initial goal in reducing maternal mortality was not reached, and still 300,000 women around the world die every year from preventable causes related to pregnancy and childbirth. So why didn't we succeed? Well, we must look at where these deaths are occurring, and 99% of maternal deaths occur in developing countries. A big part of the discrepancy between developing and developed countries is political will. For example, in Nigeria, plans were implemented to decrease maternal morbidity by 75%, but the government's unwillingness to fund this is why the risk of maternal death is currently 1 in 100. Next, lack of access. Many women in developing countries attend antenatal care, but don't deliver babies in healthcare facilities due to costs of travel and supplies that they are expected to have funded themselves. Thus, obstetric emergencies have poorer outcomes. Fear of abuse by healthcare workers is another barrier to women seeking the healthcare in African countries. There is a fear of rejection due to not being able to afford the required supplies, and of disrespect towards their traditions and beliefs. Globally, pregnancy complications are the leading cause of death for girls between 15 and 19. 99% of this is in developing countries where many pregnancies are not wanted or planned. Social pressures such as child marriage, lack of education, and access to contraception continues to prevent a decrease in adolescent pregnancies. Developed countries have progressed well, but socioeconomic status is still an issue within countries. For example, here women without access to Medicare, such as refugees, are often less compliant and attend less visits. Also, violence against women affects not only the developing world, but our society. A study found that 15% of women in New Zealand had suffered from intimate partner-related violence while pregnant. This abuse leads to not only physical harm, but increased risk of depression and mental illness. It is obvious that each country and society have unique barriers, and to progress, we must implement changes specific to their needs.
In recent times, there has been a plateau on the rate of annual reduction of maternal mortality. Similarly, since 2013, there has been a plateau of health funds diverted to developmental assistance for these programs. The question of how we continue to reduce maternal mortality requires a complex solution that spans across multiple agencies at international and national levels. At the international level, safe motherhood is an issue that does not fall to a specific UN agency, and that is why the Safe Motherhood Interagency Group exists. It involves the WHO, UNICEF, UNFPA, the World Bank, and other organisations. And whilst this can work to the advantage of having multiple programs run by different agencies, as well as pooled resources, there are also many detriments. Namely, there is a lack of unity from an external perspective and a lack of clear consensus around interventions and strategies. Collaboration is also required among local agencies within countries to successfully implement strategies at a scale large enough to make an impact. Involvement of the private sector is also imperative to secure the necessary funding. So what are our proposals for program renewal? A single UN agency that can collaborate and liaise with existing partnerships between agencies whilst acting as a united entity. Having a global champion for the cause who is a highly visible media figure. Develop assessment methodologies that are cost effective, because currently it's technically difficult to estimate maternal mortality, which makes it hard to measure progress and the impact of programs. And perhaps most importantly is hammering out a consensus. Not every agency needs to implement the exact same interventions, but if governments are to address the issues, and if donors are to fund the programs, a core set of recommendations must be endorsed by the key institutional players. Ultimately, we believe the key is to focus on policy, education, and collaboration with the private sector.